Hello, I am Dr. Madhuchanda. I am MD Medicine. I'll be speaking on ARB usage in COVID-19. To date, the 2019 novel coronavirus outbreak is being a major concern of the scientific community to treat with potential medications. Following a rapid increase in the cases of COVID-19, different observational studies are undertaken to identify the potential risk factor for infection and related poor outcomes. 70% diabetes cases are reported among 52 critically ill patients with COVID-19, and 16.2% diabetes mellitus and 23.7% hypertension cases were identified from 1099 patients by Guan et al. Similarly, out of 140 hospitalized patients, 12% diabetes mellitus cases and 13% hypertensive cases were observed in critically ill patients with COVID-19. Hypertension was independently associated with the severity of COVID-19 on admission. Hypertension is a risk factor for aggravation of the disease in COVID-19 patients. The large percentage of patients with hypertension undertaking SCE inhibitor or angiotensin receptor blockers was a remarkable characteristic among those presenting severe COVID-19 manifestations. These are classes of antihypertensive massively used as first-line therapy due to their additional kidney and cardiologic protections that occur regardless of their use for blood pressure control. SCE inhibitor, SCE2 is established as a functional receptor for the entry of SARS-CoV-2 into cells. SARS-CoV-2 enters the host epithelial cell after its spike protein's receptor binding domain binds to the membrane-bound SCE2 receptor. SCE2 is a type 1 integral membrane glycoprotein. The highest expression of SCE2 is observed in the kidney, the endothelium, the lungs, and in the heart. The probable rationale proposed for the possible relation between the use of SCE inhibitor or ARBs and progression to ARDS in COVID-19 is the increased availability of SCE2 attached to surface in the lung endothelium, an inherent effect of these two classes, leading to enhanced coupling of SARS-CoV-2 to SCE2 and its consequent cell entry. A receptor binding domain of the SARS-CoV-2 has a stronger interaction with SCE2, and any increase of SCE2 expression may potentially amplify the virus capacity to enter the cells. Distinctly, ARBs increase angiotensin II availability since this class blocks its coupling with AT2 receptor, leading to compensatory upregulation of SCE2 in the membrane. Cellular entry is followed by endocytosis and further viral replication and subsequent release. SARS-CoV-2, after entry inside the cell, causes downregulation of further SCE2 expression. SCE2 is responsible for the conversion of angiotensin II to angiotensin I to inactive angiotensin. That is, downregulation of SCE2 results in an unopposed action of angiotensin II through its AT1, angiotensin II type 1 receptor. Angiotensin receptor blocker oppose angiotensin II's action by blocking its synthesis and receptor. ARBs may also cause overexpression of the soluble form of SCE2, which intercepts the binding of SARS-CoV-2 with membrane-bound SCE2, thus inhibiting the viral entry into the host cell. The new data published in JAMA Network Open show that after adjusting for multiple variables, COVID-19 patients treated with SCE inhibitor and ARB had a significant lower risk of death and severe adverse events, which include the need for intubation, mechanical ventilation, or admission to the ICU, when compared with those not receiving the RAS inhibitors. BRACE Corona trial, which was presented at the ESC Congress, showed that hospitalized patients with COVID-19 who continued on their previously prescribed SCE inhibitor and ARBs are not at an increased risk of dying or remaining in the hospital when compared to patients who stopped the medication. The Replace COVID trial, which was published, came to a similar conclusion. Abrupt discontinuation of therapy puts them at risk of complication or rebound exacerbation of the disease. In patients with hypertension, discontinuation or switching of a drug can lead to rebound hypertension and transient suboptimal control with the new agent, thus predisposing the patient to intermittent high BP fluctuation, which can augment the risk of developing CV events. Similarly, in heart failure patients, sudden discontinuation of SCE inhibitors has been shown to result in a deteriorating clinical status with a possible relative increase in mortality. In post-myocardial infarction patients with LVD, RAS blockade provides mortality benefit. Similarly, the use of SCE inhibitor or angiotensin receptor blocker reduces the risk of diabetic complication in patients with diabetes mellitus. Until more data become available, we feel that continuation of SCE inhibitor or ARB may or may not increase susceptibility to SARS-CoV-2 infection. But sudden discontinuation of SCE inhibitor or ARB is more likely to result in decompensation of previously stable clinical state. Therefore, based on this data, European Society of Cardiology and American College of Cardiology or American Heart Association does not recommend the discontinuation of SCE inhibitor or ARB therapy in patients with heart failure, hypertension, or myocardial infarction who are also suffering from SARS-CoV-2 infection. Moreover, SCE2, whose expression is enhanced with an SCE inhibitor or ARB therapy, has the ability to suppress inflammation and has been suggested as a potential new therapy for inflammatory lung diseases, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves a direct causal relationship between the use of SCE inhibitor or ARB and COVID-19 infectivity or mortality, and the facts that SCE inhibitor or ARB may have benefits in CV disease. Thank you.